Thank you for joining us for Talking Sleep, a podcast of the American Academy of Sleep Medicine. I'm your host, Dr. Seema Khosla, Medical Director of the North Dakota Center for Sleep in Fargo. Today's episode is sponsored by AASM. For those of us who have been AASM members for years, do you ever wonder how a clinical practice guideline comes to be? Who decides on the topics and the frequency of the updates? Who decides where the annual meeting is? Who decides which clinics are formed and which are sunset? What about patient advocacy and lobbying or advocacy for higher reimbursement? Today, we are chatting with Dr. Anita Shelgikar, the current president of the AASM. She is here to shed light on what happens behind the scenes at the AASM. She is a neurologist and sleep fellowship program director at the University of Michigan and is here to provide more transparency about what goes on at those board meetings and how the AASM makes all of those important decisions. Thanks for being here today and being willing to be in the hot seat.
Seema, thanks so much for having me, and thanks for all that you do in this podcast. It's such a joy to be here with you.
Oh, aren't you sweet? You're trying to butter me up so I get rid of the hard questions, right?
You got me.
So can I ask you something I've wondered for
Please.
a while? Why does it take so long to get an update to a clinical practice guideline?
Thank you, Seema, for asking about the clinical practice guidelines. This is something that our members have cited as one of the key values to AASM membership. And we know that they are referenced not only by our own members, but by other people who are taking care of patients with sleep disorders. And so that responsibility of putting evidence out there to guide patient care is something that we take very seriously. And so we know those guidelines have to be developed with rigor. And that's part of then what feeds into the length of time that it takes to generate a guideline, because we use a process called GRADE, which is a very structured process of gathering evidence and looking at all of the data and rendering recommendations in a very structured format. And all of that takes time. And so we end up with a very robust product, but the downside is the time that it took to get there. So we recognize that evidence moves at a very fast pace and care evolves at a fast pace, and we need to be better about keeping up with that speed. And so we are working to streamline our guideline development process and trying to separate out development of completely new guidelines from focused updates of existing guidelines when there are enough new data to merit a focused update. And we're hoping that by separating these two prongs of the guidelines, that we can then have updates available more quickly and then spend the time needed, but hopefully still a quicker amount of time to generate brand new guidelines as well.
So are the guidelines updated just kind of as they get old, or like how do you develop new ones, or who has a say in which guidelines get developed?
This is a really excellent question about clinical practice guideline development. So I would encourage anybody who's interested in this topic and wanting to learn more to visit the standards and guidelines section on the AASM website. And there are detailed descriptions of the guideline development process, which guidelines are in development. And to give you a little bit of insight into the guideline development process, the GAP, which I mentioned, the AASM's Guidelines Advisory Panel, reviews suggested topics that they hear about either from members or other guideline panels that are currently in existence, task forces working on current guidelines, really trying to keep their finger on the pulse of where is the need right now. And once all of these topics are collected, they will look at a number of factors, particularly the amount of data that exists to generate a robust clinical practice guideline. And then the GAP will prioritize based on when was the last time a guideline was published, if there has never been a guideline on a topic published, and make recommendations to the board of directors about which topics should be prioritized and kind of what should be next on deck for developing task forces and working towards executing and the development of a guideline. So in that process, once the topics are approved, the task forces are convened as it goes through that grade process I was telling you about. There is a part of the process that includes public comment period. And so that happens before the guidelines are approved for final publication. So there is an opportunity for people to weigh in that guideline development process as well.
So is that a committee then?
So the Guidelines Advisory Panel is a volunteer group that is selected by the board of directors. And then for each topic that is selected for guideline development, there is a distinct task force for each of those guidelines. So the GAP, the Guidelines Advisory Panel, is overseeing a number of task forces for each of these guidelines and updates that are in development.
I mean, there's a lot of committees, right? So how do you know when you need a new committee and when to sunset one? Is there sort of like a set number and then you just like roll one off and on-roll another one? Or like, how does that whole thing work with the committees?
There are a number of committees, which I think speaks to the enthusiasm of our members and willingness and desire to be engaged and volunteer, and also the magnitude of work that needs to be done on behalf of the AASM and our members and our patients. And so we really try to use our guiding lights being our mission and vision for the Academy and our strategic goals, and thinking about what volunteer groups do we need to help us move forward in terms of each of our strategic goals, our mission, and our vision. And so it's not about having a set number of volunteer groups. It's really about, do we have a group convened that can help us make progress in any one of these areas?
So, one thing I've always kind of talked about is that I think it's super important that everybody has a chance to be heard and to be, part of this tapestry of this field that we all love of sleep medicine. And when I think about it, I think a lot of that voice and that impact happens through volunteerism and committee work. So why is it that, everybody who wants to volunteer, how come some people don't get to?
Thank you for this important question. I wholeheartedly agree with you that our members are our lifeblood. We are over 9,000 strong and so grateful to each of our members. And absolutely, our members should have an opportunity to volunteer with the Academy. This is something that was very important to me as I was coming into the president role. I was the chair of the Committee on Committees, which is the group that does the volunteer assignments and refines the goals and mandates for each volunteer group that then goes to the board for final approval, and really wanted it to be a goal of the Academy that we have 100% volunteer placement rate, because we really do want to engage every single member who wants to volunteer for the Academy. And I'm proud to say that we accomplished that through the development of the AASM Strategic Ambassador Program. It's now a part of the annual call for volunteers that goes out in February. And so these strategic ambassador roles are one-year appointments with an annual opportunity for reappointment. And there are 6 of them. So early career ambassadors, education ambassadors, emerging technology ambassadors, membership ambassadors, public education ambassadors, and social media ambassadors. So if any one of those sounds like an opportunity or a passion for somebody, I wholeheartedly encourage them to look for the call when it goes out in February.
Oh, okay. That's actually really cool, because over the years, I have heard that from a lot of people where they're like, hey, how come you got to volunteer? I applied and I didn't get to. And I was like, I don't know.
Yeah, I agree with you. I think when you want to invest your time and share your enthusiasm and are told thanks but no thanks and try again next year, it's really hard. And I've been on the receiving end of that too, so I get it. And I'm really excited that we were able to take this goal to heart. The board embraced it, the senior staff totally embraced it, and I think it's a testament to the dedication to our members and also to the creativity of the AASM to think about development of these strategic ambassador roles and being able to offer these opportunities to everybody who wants to engage.
That's awesome. I'll have to let my friend know.
Exactly.
So we did let people know that you were going to be a guest. So we put a post on social media. And so we have a few questions that they wanted to ask. So I thought I'd start with one from Matt Horsnell. So as you know, he is this tremendous patient advocate for sleep disorders. He goes to the conferences. He does a lot of patient advocacy and Hill Day and so on and so forth. So he wants to know how patient advocacy and the AASM can collaborate to support bipartisan legislation in this challenging political climate.
Well, hello, Matt, and thanks for all you do, and thank you for the question. I wholeheartedly agree that partnership between the AASM and patients is critical to be able to collectively advocate for our shared goals, what we think is important. And from our standpoint at the Academy, that's really staying focused on our vision and our mission. And just as a reminder, our vision is sleep and circadian care is fundamental to healthcare, and our mission is advancing sleep care and enhancing sleep health to improve lives. And those two things are our guiding lights when we are thinking about all of our activities at the Academy, and our partnership with patient organizations and our advocacy efforts are also very much influenced by our commitment to our vision and mission. And so I think when we are talking about what's important for patients and what's important for AASM members to properly take care of all patients and deliver care in an evidence-based way to all patients in all communities and maintain that patient-centered focus is really where we can have an impact and really try to engage bipartisan support for what we're advocating for on local and federal levels.
Well, and don't you think, too, that sometimes when we talk about sleep, like sleep is not a partisan issue, right? Like this is one of those areas that I think we all have in common. We all need sleep. And certainly, hopefully by appealing to those areas that are common, right? Perhaps we can have bipartisan legislation to look at the big picture and to help support, just standard sleep health overall, but also more advocacy for sleep disorders, more funding for sleep disorders. And so I think, to me, I'm hoping that, and I think what he's trying to accomplish is to see how we can still move forward, even though there's been so much politicization of, just about anything, that maybe this is something that can maybe be a little bit neutral.
I agree with you. Sleep is a human issue. It's not a partisan issue. Yeah. And it cross-cuts through every aspect of our lives, right? It affects so many organ systems, so many of our biological processes, every age group, every community. So absolutely, these are the things that we all hold as critical to what we do in our day-to-day role as clinicians, as researchers, as patients, as family members to people with sleep disorders. And so absolutely, I think this is a human issue, and that's where we can really try to gain ground from a legislative standpoint to really focus again on what's human and what's patient-centered and why sleep health is so important for everybody.
So we have a question from Dr. Neeraj Kaplish, who is interested in the insights you might share with young adults thinking about sleep medicine as a career path.
So sleep medicine is one of the most dynamic fields right now. I think all of us who are practicing in it can attest to that. It has evolved so much in 50 years' time, and what we are seeing in terms of emerging technologies, both for diagnostics and therapeutics, new ways to deliver care to people who previously did not have access to sleep health care. I mean, there are so many things that are up and coming in our field that make it vibrant, that make it dynamic, that make it fun to learn. And so I think there are all of those reasons to pursue a career in sleep medicine. And I think many of us who see patients on a day-to-day basis feel like it's so gratifying too, because when people sleep better, they feel better. And it's so meaningful to know that we can help people achieve a higher quality of life.
So let's take a short break. And when we come back, we'll talk more about the inner workings of the AASM. You're listening to Talking Sleep from the American Academy of Sleep Medicine. Welcome back to Talking Sleep. We're talking with current AASM President Anita Shelgikar, who is here to answer our questions about what happens at the AASM. All right, so let me toss another one I've been thinking about. I understand that the HSAT codes are being reviewed. What does that mean?
So the HSAT codes, the unattended sleep testing codes, those are due to be updated. So the AASM partnered with the American Academy of Neurology, American College of Chest Physicians, otherwise known as CHEST, and the American Thoracic Society to update the unattended sleep testing CPT code family. And this was for a few different reasons. Number one, to be inclusive of newer technologies, and number two, to expand the use of unattended sleep testing codes to be able to capture testing for multiple sleep disorders instead of being limited to diagnostic testing for obstructive sleep apnea exclusively.
Ooh, that's interesting. Okay, and I appreciate, I know that this information has been embargoed. What can you share about the upcoming changes?
Sure. As you noted, due to the American Medical Association's or AMA's confidentiality agreement, we can only provide high-level descriptions of the codes. But what I can share with you is that CPT codes 95800, 95801, and 95806 will be deleted and no longer available for reporting as of January 1, 2027. And the code family will contain 3 practice and technical component only codes, and then 3 physician work or professional component codes. And so the complexity will be low, moderate, high, and then again, a technical component only and a physician work component only. And the complexity level will be based on the number of channels that generate a minimum number of parameter categories. So yes, more to follow, certainly at the upcoming sleep meeting in June in Baltimore. And then as we are allowed to share more detailed information, we certainly want to make sure that our members are ready when these new codes go into effect January 1st, 2027.
So, which will help with all of the novel sleep technology, right, that we're seeing?
Oh, that is our hope. Yes, our hope is to be adaptable and responsive, in real time to the way we practice.
So, and I'm not trying to be a negative Nancy, because I'm a very optimistic, positive, glasses half full kind of girl. However, I feel like reimbursement just continues to fall. Like every year, it just seems like it's kind of this race to the bottom, right? And so I am, and I say this wearing my solo practice hat, I'm worried about the financial viability of our field. Tell me your thoughts.
I hear that loud and clear. We know that financial viability, financial sustainability is paramount for our field to continue, for people to keep their doors open, to be able to serve patients. So we do not take that lightly at all, and fully agree that this is a priority for everybody in our field, particularly our patients, so that they can get the care that they need. And so I think this is exactly why we are engaged in advocacy. Circling back to Matt's question about engaging in shared advocacy efforts, I think the patient voice is critical to make sure that legislators understand the importance of patients having access to this. And part of access is meaning that they are covered, these services are covered and reimbursable. Also, I think it's important for us as a field to think about the diversity of and the breadth of sleep disorders and sleep-wake disorders that we diagnose and treat, and really broadening our ability to diagnose sleep-wake disorders accurately, to treat them, to think about how to customize our approach to diagnosis and treatment. And I think in that broadening of the scope in some ways, as new technologies come about, as new research is implemented into the way we practice, I think that also will give an opportunity for hopefully diversifying the amount of reimbursable activities that we participate in.
Yeah, because that's the thing that I'm a little bit concerned about. Do you see our field then? So I guess I'm hearing something different, because I was imagining that our field would become sort of this chronic disease management with reimbursement that's sort of E&M coding from clinic visits. So then it becomes more of a primary care model without as many procedural codes. Is that... But what I'm hearing you say is that there may be opportunity for different procedural-based ways of diagnosing sleep-wake disorders. Am I understanding you right?
I think you're asking a really important question. I'm sure if we got many members in a room, we could have a lively discussion about this very topic. And I would like to say, maybe this is me being optimistic as well. I share your optimistic viewpoint of a yes and. I think we do engage in chronic disease management and chronic care. I think that's part of what makes our day-to-day work so meaningful, that we do establish rapport with patients on a long-term basis and really get to be part of their journey towards improved quality of life through improved sleep and better alertness during the day. And we know that there are emerging technologies that are being used for more accurate and timely diagnosis of sleep disorders, for more precise and broader scope of treatment of sleep disorders. So I think there is promise there too for thinking differently, thinking creatively about the way we practice, and that there may be new opportunities there. There are certainly so many people who are really doing cutting edge work to look into these very things, all again from the lens of being able to better serve our patients. And I think that it will be a yes and.
So do you see a role for a more robust inpatient sleep medicine service?
I think this is the inpatient setting is certainly a care setting where there is a need in terms of identification and timely management of sleep disorders for appropriate patients. And as you may be aware, there is a recent clinical practice guideline on the evaluation and management of obstructive sleep apnea in adults who are hospitalized. And this is available online at JCSM, online ahead of print, just from August of this year. So absolutely, this is something to consider, again, when a practice setting has the resources to be able to have an inpatient consultation service. But certainly there is a role for that, again, inappropriately selected patients, depending on what other comorbidities are being managed acutely in the inpatient setting. But I definitely think there is a potential role there.
So we have had conversations about the role of PSG for many, many years. And we've talked about these really cutting edge, could we do EEG fingerprinting? And, Dr. Mignot talks about the hypnodensity and can we diagnose narcolepsy based on the overnight polysomnography? And so this has always led to this question of how can we improve the value of the polysomnography rather than this sort of reductive way we look at it as tons of signals to generate an AHI. Like how can we improve the value of the test we're already doing?
Seema, that's a great question. I agree with you. When we are looking at many, many hours of raw data, there are so many data that we are looking at on the PSG, and really thinking about what are those data telling us that in a way that we're not looking at right now. And so the AASM has convened a re-envisioning adult OSA characterization task force to look at this and to really develop a systematic process to create a new framework that addresses the limitations of the current apnea-hypopnea index. The HI has its role, but as you mentioned, it has its limitations as well. And so we really want to go about this in a systematic way. And so this task force is started with a steering committee who is identifying other people from all over the globe, experts in the space of OSA and also in the space of characterization schemes, learning lessons from other disciplines and other classification systems that have been developed for other disease processes. And this group right now is establishing a process to develop a framework. And so that work is ongoing, but really speaks to the question you asked about how do we get more value out of the data we are collecting and really try to think about characterizing OSA in a more nuanced and precise way.
The AASM had a webinar celebrating the 50th anniversary of the AASM. And as part of that, we were chatting with Dr. Tom Roth about how the field has changed over the last 50 years. And so this ties into a question that came through Twitter by Dr. William Healy. And his question was, what are some of the priority areas of the AASM as we enter the next 50 years of growth and advancement?
Thank you for the question, Dr. Healy. It's a really exciting time to be here in sleep medicine right now. Seema, we just talked about something in terms of being able to use the PSG that we routinely use, but use it in a different way to look at the data we're collecting and better characterize obstructive sleep apnea. So that's a burgeoning effort right now that I think will definitely play out in the next 50 years and hopefully positively influence the way we are able to diagnose and treat obstructive sleep apnea. We are also really excited about the opportunity for partnerships with primary care endocrinology when we think about our patients who have obesity and obstructive sleep apnea. Certainly new therapies available for patients. And so I think this is an area that will continue to evolve for our sleep medicine community. And that's an opportunity there as well. And then also thinking about really better understanding sleep in women. And that's a task force that's been created as well at the Academy to identify gaps and opportunities to improve sleep care for women across the lifespan. So I think a lot of this is tying around a central theme of better understanding nuance and being able to personalize the care that we provide to people with sleep disorders.
So let's talk about potential new technologies. What do you think about acoustic stimulation? Where do you see this headed?
Well, it's hard for me to weigh in on any one new technology, but I do think if we zoom out a little bit and think about the number of emerging technologies related to either, sleep symptoms or alertness, or anything along the spectrum related to what people tell us about when they are coming into our clinics. I think we are just seeing this such a rapid increase in terms of the accessibility of these new technologies to our patients directly. Also, every time we go to the annual meeting, right, we see and hear about new technologies that are either in process or now available. And so I think we're going to see a lot of evolutions in a good way in terms of the way we practice. I think this is where opportunity lies. Speaking back to Dr. Healy's questions about what may the next 50 years look like, I think it's going to be a period of a lot of opportunity and growth for our field as we continue to develop these technologies and be able to implement them in our clinical care.
So I feel like there's a ton of stuff that happens at the AASM that no one knows about. I think AASM does a great job of communication, right? Like you get the Saturday newsletter and there's an email and there's something else. And but there's still a lot of stuff that we don't know about. So do you want to do wins or losses first?
Oh, let's start with good news first.
What are some of the recent wins that the AASM has had?
Sure. So one of the recent wins at the AASM is the development and the finalization of PLATO, the patient-reported longitudinal assessment tool for OSA. And so this is a questionnaire that the Academy developed through work with an outside consultant. It was led by an expert panel of members. This process took a long time. It spanned the pandemic. It was a very iterative process and went through a lot of data collection and fine-tuning to get to the final product, which is being termed PLATO. And so the manuscript is available on the JCSM site as an accepted paper, and the questionnaire will be available in English and Spanish through an online platform. And one of the exciting aspects of this is that clinicians and researchers will be able to download and use the questionnaire for free. And so we're really hoping that this provides some consistency in terms of being able to navigate response over time, and also, helping with having quote unquote common platform to really drive future research so that when we are trying to advocate on behalf of our field, on behalf of our patients, that we have more consistent endpoints in the studies that are done. And so that's one big win that we're really excited about. Also, in terms of growing our field and the sleep team, including sleep physicians, the Advancing Innovation in Residency Education, or AIR program has been successful, and we've been growing the number of sleep medicine doctors. So we're excited about that. There was a record match of 207 physicians in December 2024. In terms of the sleep team, our advanced practice providers, our technologists, we are seeing at the Academy that the sleep team cohort of our membership is the one that is growing really quickly. And so I think that too speaks to the need in our field for people who are committed to taking care of patients with sleep disorders. So I would say those are two big wins as well.
So what about some losses?
The losses.
I mean, to be fair, right? Like
yes. It's a good question.
There's good and bad, right?
It's an important question, and I'm glad you asked it. So years ago, when I'd gone to a leadership development session put on by the Academy, by the AASM, the speaker had said, "If you never fail, then you're not innovating," and that really stuck with me. And I think the Academy really takes that to heart too. That in order to innovate, in order to be on the cutting edge, it means that at times we may not accomplish what we were hoping to with a given initiative. So one example would be the Sleep TM platform that we thought would address a need with having a telehealth platform that was specific to sleep medicine clinicians. But as you know, many healthcare systems have the telehealth platform embedded into their own electronic health record. And so it didn't really make sense then for the AASM to be spending resources on the maintenance of a sleep telehealth platform when that type of platform was more readily accessible to our members through different channels. And so I think the importance is having the humility to say, okay, what are we doing? Why are we doing it? Is it working? Is it not working? And if the answer is no, then that's okay. And what do we learn from it? And how do we pivot to something that will continue to add value to our members and our patients?
But
so
you know what was cool about Sleep TM though, is that came out way before the pandemic.
Yes. So we're trying to be on the cutting edge, and I think oftentimes we are. And we exist as part of the dynamic ecosystem of healthcare in general. And so as things evolve, we have to evolve also. And so that means keeping close tabs on what we are doing and how each of those initiatives are progressing. And if the answer is, we thought this was going to be a win, but it turns out not to be, then, we just acknowledge that with grace and we learn from it and we move on so that we can keep our eye on our mission and our vision and really make sure that we are doing what's best for our members and for our patients.
So you gave us 2 wins. You've got to give us at least 2 losses.
Okay. The other loss, I would say we had tried the Welltrinsic platform many years ago as well. Again, well-intentioned and thought this could be a product to offer employers and to, kind of be a distinct offering from the AASM. And, we gave it a full, wholehearted effort, and it just didn't pan out that way. And I think sometimes when you venture into these spaces, you learn the complexity of being in a certain marketplace. And does it play to our strengths? Does it not play to our strengths? Do we have the footing that we need to really be successful in that regard? And, we had to ask some hard questions and tried retooling things a little bit here and there. And ultimately, when the board took a hard look at it, the answer was, okay, we had the intentions in the right place, but, this didn't pan out the way we had hoped, and that's okay. And what are the lessons learned, and where do we focus our time and energy now to add value?
2025 marks the 50th anniversary of the AASM. Anita, I'd love for you to introduce our 50th anniversary clip.
Thank you, Seema. I'm excited to introduce the clip from Dr. Faria Abbasi-Feinberg, a dear friend and colleague on the board with me and our current president-elect, and I'm excited for her to take the helm at the Sleep 2026 meeting in Baltimore.
I always tell people that being part of the Academy has balanced my life. I love taking care of patients. I'm very involved with the clinical aspect of my day-to-day practice, obviously. But there's something about doing or being involved with the Academy that is so much bigger than me, my patients, and my practice, that it gives me a bigger why. It gives me a sense of satisfaction. And there's been a lot of personal growth for me being a member of the board of directors. I see that the American Academy of Sleep Medicine is growing. I look at it like we're maturing. It's sort of like when we grow as an individual, right? You first have to become independent. And then once you're strongly independent, you can become interdependent. I feel like the Academy is there now and over the last few years, and it's going to continue to occur that way, where we grew as a field and we're independent, and now we're becoming more interdependent. We're working synergistically with our sister societies, with payers. We're hoping to work with patient advocacy groups and even industry. I think I really like that African proverb that says, if you want to go fast, go alone, but if you want to go far, go together. And I feel like the Academy is at that change now where we're working together to do what's really best for our membership and our patients.
Now back to our conversation. So how can members engage more?
So there are many ways to engage with the AASM. On a day-to-day level, if you would like to reach out to your legislators, then you can find on the advocacy section on our website how to do that, how to send off notifications and letters and requests to local legislators. So that's one way to get involved. On the AASM Engage platform, you'll also find the notices that you see in the Weekly Insider as well when there's a call for volunteers. The big annual call for volunteers will go out in the early winter. So keep an eye out for that. Again, we have these strategic ambassador programs now that give an opportunity for everyone who wants to be involved with the Academy. And then sometimes when we develop task forces kind of off cycle, which doesn't happen often, but does happen depending on what's timely and what's necessary, then we will put out kind of an off-cycle call for volunteers, and we will post those through the usual channels, through the platform and our weekly communications as well.
Isn't that funny? Because early winter for me in Minnesota is very different than early winter in Florida.
Fair point. Okay, so by early winter, I mean on the calendar, so February. Important clarification.
We are well into winter in my neck of the woods in February.
That's a fair point. Fair point.
So if there's something that you wanted our sleep medicine colleagues to know about what happens on the AASM board, what would that be? Like, what happens when you guys meet?
So the AASM board meets quarterly. So we meet, if we're sticking to seasons, we meet, summer, fall, winter, and spring. And then we meet at the annual meeting every year as well. And we try to stay really kind of at that 10,000 foot level on a very strategic level. Certainly, we take our fiduciary responsibilities very seriously in terms of governance and adherence to our budget and being fiscally responsible and maintaining the integrity of the organization. And we will weigh in when our volunteer groups need approval for something. For example, we talked in detail about the guidelines development process. So when a guideline is coming up to the point that it is ready to go for public comment, then the board will review that request and say, yes, go ahead, put it out for public comment. After that public comment period, then the board ultimately will give approval for publication. So the board is doing a lot of that type of work, like, again, not trying to redo or replicate the work of our volunteer groups, but really to keep that strategic focus and keep our eye on the future and where we need to be going as an organization. So we meet quarterly as a full group to do that. We have an executive committee and other board committees that meet more often to kind of do some of the more operational things. But when we convene as a group, we're really thinking about how do we keep pushing the field forward.
How long are the meetings?
They last anyway from 1.5 to 3 days, 2 to 3 days.
Holy smoke.
Yeah,
So this is
yeah.
not just like an afternoon.
No, definitely not.
Ah,
Definitely not.
and I've
But
heard rumors that the prep for the meeting is a lot of paperwork.
well, there's a lot to review, but it's work we take very seriously. And I will speak on behalf of all of my board colleagues. It's work that we absolutely love and feel very grateful to be able to do on behalf of our peers and our members. So it's a responsibility that we take to heart. And so we definitely take our time to prepare.
But I think that's important, right? Like, this is not just an honorific. This is work that you guys are doing, and you're, getting different opinions, and you're looking at data, and you're being strategic, and it, it takes time.
Absolutely. I would also like to shout out to the entire AASM staff. At our board meetings, we have the senior staff and our executive director there as well. And they are fantastic and so incredibly committed to the organization. And so all of us working in concert together, really thinking about our mission, our vision, our strategic goals. How do we play to our strengths? How do we use our resources most wisely, most effectively? This is the work that we do when we convene on the board. And I agree, it's not honorific. I really think it's work that we all take to heart and take very seriously because we know that we are advocating on behalf of all of our members and our patients. And so we want to do right by each one of them.
So who gets to be on the board? Is it sort of reserved for people with academic backgrounds?
No, absolutely not. We have a few board members who are not in academic settings, and that's really critical. We really do look at ourselves as a group that represents, as best as we can, all of our members. And the only way we can do that is to have multiple perspectives at the table. I do fully acknowledge that certain practice settings may be more difficult to be able to give that type of time to do the work. So I recognize, that oftentimes people in academic settings are the ones who are able to carve out that time to be able to serve. And so I don't take that lightly at all, but just want to emphasize that it really is so important for us to have all of those perspectives at the table, people serving in different communities, representing our membership and representing our patients. So we welcome people from all different practice settings, different geographic regions, different perspectives to be engaged in our volunteer groups and, to also apply for the board because we need all of those perspectives to be able to do the work that we want to do the way we want to do it.
So is that the process and people can just submit an application or do they need to be nominated?
So you'll see the call for nominations. There is some documentation required for the application to serve on the board. And so that will go out shortly. I think it's usually November that goes out. And so there is some requisite documentation. Certainly encourage people who have been involved as task force or committee members and chairs and have had some experience working in different spaces in the academy to consider applying for the board. And for someone who feels like, I'm not there yet, then, you can start small as an ambassador and kind of as your schedule and other things allow to get more engaged with the academy and to spend time serving on other volunteer groups, committees, task forces, panels, and to really become immersed in the society and in the academy. And I think that then kind of lends itself to at some point, thinking about yourself as, someone who could apply for the board. So yes, open to all, but definitely, after having some time in volunteer roles.
I love the idea of the sleep ambassador.
Oh, yay. Well, that makes me happy. Thank you. I'm excited about it too.
So any takeaway messages for us? Any final thoughts?
I want to say thank you for having me on here today. I am thrilled to be here and to talk about something that is near and dear to our hearts, which is the AASM. And I would welcome any further questions that people may have, but just want to thank our members for all that they do for the Academy and for our patients, and just that we are all here working together to improve sleep health for all.
Well, thank you for joining us today and helping us better understand how important decisions are made at the AASM. And you've kind of allowed us a glimpse behind the curtain, so we're very appreciative. Thank you.
Thank you so much, Seema.
Thanks for listening to Talking Sleep, brought to you by the American Academy of Sleep Medicine. For more podcast episodes, please visit our website at aasm.org. You can also subscribe through your favorite podcast service. And if you enjoyed this episode, please take a moment to leave a rating or review. For more feedback or suggestions, email us at podcast@aasm.org. I hope you'll join us again for more Talking Sleep. Until next time, this is Seema Khosla, encouraging you to sleep well so you can live well.